First of all, I would like to thank the organizing committee for their kind invitation. Personally, I am honored to be here in this annual meeting. Today, I talk about PCNL, stem manipulation, and exit strategies. This is the agenda that we will discuss. First of all, the visibility. Once you enter with your nephroscope, you may see the stone in front of you, or you may see white sign. White sign means that you are close to the mucosa, you are in need to go somewhat backward. The red out means there is clots inside the pelvic cell system. It's not a problem. You are in need just to go outside and do suction. It's directing the ambulance toward the clots. Once there is suction of the clots from the pelvic cell system, you can go inside and remove your stones. If the visibility is not good, this is one of the tips and the tricks that you can do. It goes around the inlet of the nephroscope. This video, you remove the clots with suction, and if the vision is not good, you can put a gauze at the inlet of the nephroscope in the ambulance to finalize the case. The yellow sign. Yellow out means that you are in the perinephric fat. Perinephric fat, it may be outside the kidney, or it may be you are transfixing the kidney and you are on the other side. This is depend on the length of the ambulance outside. If most of the ambulance is outside, you are mostly outside the kidney. The wire here is inside. The dilator passed and dilate the renal parenchyma, but unfortunately the ambulance is not inside. This is easy, just manipulate with the tip of the nephroscope till reaching inside the pelvic cell system. On the other side, this is stone pelvis, and you are transfixing. Most of the ambulance is inside, and I am sure from my puncture you are in need just to go backward, looking somewhat upward. You will find the pelvic cell system in front of you, and you can remove your stone. Here I am this is the perforation. Going backward, looking just upward, you will find the pelvic cell system, and you can remove your stones. Lost track. What are the causes of lost track? First of all, under anesthesia. I prefer to do PCNL under general anesthesia to control any movement and to be able to puncture the fixed kidney. Under spinal, mostly the kidney moving up and down, and you cannot puncture the calyx exactly. One of the most important under general anesthesia, the anesthetist should stay beside the patient. And if it is under spinal anesthesia, also take care of any sudden movement of the patient. Another cause of lost track, when you are removing big stones, the assistant should say stop. If you try to remove a big stone without disintegration, you are easy to extract the ambulance with you. I'll show this a very interesting case. The assistant say to me stop, but I don't obey him. What is the end reason? I remove the stone. It's okay, but what ended? There is a complete cut of the ambulance sheath. She says it's completely cut with the stone, which is very dangerous. This is a hydronephrotic kidney, so no bleeding occurred, but in normal kidney, this will end in marked bleeding, and you can remove bigger stones once the ambulance is open. This is not good. This is the ambulance complete cut, so it's late. The other causes of lost track, not well settled ambulance in case of a stone filling the pelvic cell system. And very important, you have to know the length of the ambulance. The standard one is 17 centimeters, and we use it in all cases. But in cases of horseshoe kidney, you are in need for longer one, what's called extra long ambulance and extra long nephroscope. Also, this obese patient. For pediatric, you are in need for short. No short ambulance is available in the market, but we cut it. We are in need to use short one. If we use the standard one in pediatric, so just 3 or 4 centimeters will be inside, and 13 centimeters will be outside. This may let the ambulance easily lost during the manipulation. Lost track. How you there will be very important. How to diagnose? You will find yourself outside, there will be bleeding. I'll show you this video to know the picture of the kidney from outside. You should know, as all of us know the picture of the kidney from inside and the picture of the pelvic cell system also. You should know the picture from outside. Here I am outside. This is the renal parenchyma, this is the capsule, and this is the renal parenchyma. You should know this picture. Once you see this picture, you are outside. This is the hole. This is looking for the hole. We are here looking again for the hole. This is the picture of the pelvic cell system. There is a complete difference between both videos. Lost track. How to manage? First of all, try to reduce irrigation. Maybe this working and maybe not working, because once you are outside and you reduce the irrigation, there may be more bleeding. There is very important difference between lost track in a fresh case and in a cases with a previous renal surgery. This is a big issue, but one of the advantages of the previous renal surgery is that once you lost, you can go inside easily. I'll show you. Here I am inside. I'm sorry, how to manage a lost track is not this video. This is the case. You are, as we said, you should follow the safety wire looking for the track. It is easy once you follow the safety wire, or you are looking for the orifice. Once you are beside, we are looking for the hole in the parenchyma. You may be lucky and find it, and you may not easy to find it. The difference between fresh cases, this is the case with previous renal surgery. I am outside and go inside again easily because it is a fibrosed way. So once you are lost, it will not be easy to return inside again. The opposite in a case of fresh kidney. You may not easy to return again in a case with fresh kidney, but because the way is not paved. Once I go outside, it is mostly the tissue closed in front of me, so you may not easily to find your way again when compared with the case of previous renal surgery. There is one of the tips and tricks we did it. As we know, the pelvic cell system is a closed system. You can use the hydrophilic wire wandering inside the pelvic cell system. If your axis is the upper calyx or the lower calyx, you may succeed that this wire take its way in the lost track. This is the case. I'm outside. This is a hydrophilic zebra wire. I bought it from the orthotic caster. It will be coiled looking for the orifice. It may succeed. Here, the wire find its way and succeeded, and it is passed beside the ambulance. Once we find the guide wire, here it finds its way. This is one tips and tricks. It may succeed and it may not, but it's good and you can guide you again to your track. It is very difficult. You can inject methylene blue from the orthotic caster, but it will not be easy. And even if you try to repuncture it, the calyx will be collapsed and there will be extravasation, and even if with sonar it will not be easily. You can try another calyx, or very rare you postpone the case. Sometimes under fluoroscopy you find the stone in front of the tip of the nephroscope, but it's intraoperative no stone. So how to deal with the case? You have to look upward. Mostly you find the stone here, the stone in front of you, this post-equivalence plexi. You can with your tip of nephroscope relocate it in front of you. Here another stone in front of the nephroscope, but actually I didn't see it. You can with the needle just manipulate the stone here, the stone, look for the tip of the stone, with the needle try to manipulate it to deliver it in front of the nephroscope. This is a very small space, even the flexible will not be easily to use in this situation. Look to the tip of the needle here. I just try to put and deliver the stone in front of the nephroscope. Very important to know the anatomy. We are lucky that the upper calyx anatomy is mediolateral and the lower calyceal anatomy mostly anteroposterior. So, this is a case, stone lower calyx, as you see in the CT. We did direct puncture to the lower calyx. We dilate the tract, put our dilator and our ambulance. We entered and disintegrate the stone. After disintegration and extraction of the stone, as we know, we take a look under fluoroscopy, but unfortunately there is same shadow. It should be revised in the pre-operative CT, and we should know that this stone, it is from the start branched stone in the lower calyx, anterior and posterior. In this case, no problem. You can go inside again because it is a posterior calyceal puncture, and you can rotate, just look forward in front of you, downward, you will find the other stone in the anterior calyx, and you can disintegrate and extract it. In this situation, no problem, and this is the final picture. But if the opposite occurs, this is a stone lower calyx, and we puncture the lower calyx, we don't concentrate with that, we puncture the anterior or the posterior, we just puncture the lower, insertion of the wire, dilatation, and just we enter, we find no stone in front of us, and the stone is present under fluoroscopy. Once you tilt to look anterior, no calyx, this means that you are punctured the anterior calyx and the stone is behind you in the posterior calyx. You cannot go from the anterior calyx to the posterior, but you can go from the posterior to the anterior. No problem. One of the tips and the tricks here is we take a wire through and through to preserve the track, remove the ambulus, and with the puncture needle, go to the stone and try to relocate it in front of the ambulus tract to the pelvis. This is what we did. With the puncture needle, just touch the stone, inject saline, or even with the puncture needle, it will be pushed to the pelvis, and reinsert your dilator and your ambulus again, so the stone in front of you, and you can remove it easily. Again, cases with previous renal surgery. This is a multiple stone. Look for this one. Under fluoroscopy, we try to puncture, the case of previous renal surgery. The shadow is fixed here. It is not moving with us. This shadow in the stone is in the perinephric space, and you should ask your radiologist to look in any case with previous renal surgery for a stone in the perinephric space. This is a case of multiple stone and the dead PCNL outside. The patient come to us after 2 months. And this is a case also with previous renal surgery. You should suspect that sometimes the shadow of the stone is embedded in the renal parenchyma. This is the picture. This is the shadow as we see here, but from inside the shadow is embedded in the renal parenchyma. So you should know all these tips and the tricks in cases with previous renal surgery. Inaccessible stone. How to manage inaccessible stone? This is a multiple stone kidney. Piece of stone escaped. It is not primary stone here. As the stone is escaped from one side to other, so you can with the needle relocate the stone again to the primary side. Also, you can use this idea to redistribute the stone from the start. This is a multiple stone here in the middle calyx. So I am not in need to do puncture here and the puncture here. You can try. It may be succeed and also it may be not, but just a trial. With the puncture needle, the stone in middle calyx, I try to relocate the stone is relocated. This is the endo picture. This is the neck of the calyx. With the puncture needle from the start to save one puncture, I try with the needle to put it, it is delivered to the pelvis and you can save one axis. The relocation with the wash. This is a very interesting case. Stone pelvis in a bifid pelvis. Okay, we puncture the lower calyx. Unfortunately, it is escaped from us to the upper moiety. The stone, we puncture the lower calyx. Once you enter and we dilate, the stone in front of us escape to the upper. We lock the stone. Once it is escaped to the upper calyx. No problem. As we said, the rule, once the stone escaped from one side, you can relocate it again. We did puncture to the upper moiety, we insert the wire, we dilate it, and unfortunately, again, the stone escaped to the second branch of the upper calyx, to this situation, to this location. And once we end up in the second puncture, we find the stone escaped again. But here I will not do a third puncture. What will I do with the puncture needle? Inject saline. You have to come with the needle from the upper part of the stone, not the middle. It is not working here because the puncture in the middle of the stone. I come, I re-puncture again. Come from the upper ball of the stone. Now the needle in the upper part. Inject saline. It is return again. But here the tips and the tricks to avoid escape to this, to fill this space with a wire. I fill the wire here, not one. I don't want this wire to come here. I would like to have the wire coiled here. So once you use this track, the stone will not escape again because I filled this space with a wire. Once you do the puncture, I finish the stone from this track and the picture is free. We can relocate stone escaped here, and the microscope cannot escape the beside the ureteric caster. Remove this ureteric caster, inject saline from the ureteric caster, the stone will escape again, and you have to close the wash from the nephroscope because not wash from down and wash from up, it will not hang. Here inject the saline, close the wash from the nephroscope, inject saline, the stone come in front of us. The same stone here in the upper ureter, but take the wash outside. Inject saline from the ureteric caster, the stone escape, return again in front of the nephroscope and remove easily. Sometimes stone escape to the upper ureter, and once you inject saline, the stone take a position that cannot relocate it again to the pelvis. The tips and tricks here with the wire, just dislodge it. It is not a primary stone in the upper ureter. It is come from the pelvis to the upper ureter. The wire dislodges the position of the stone and allow you to, when you inject saline from the ureteric caster, the stone to come again up. Here I dislodge the stone with a wire. Just dislodge it, and the wire here is passing. Dislodge the stone and allow me, once I inject saline, it is come back again to the pelvis. Basket. You should have this basket, this bird inner circle, because if the stone is not available, you can put your basket in an inaccessible stone and you can remove. Here's the stone, the upper calyx, and you have the lower calyceal axis. With this basket, you should have it intraoperative. You can remove this piece of the stone. Very interesting that the anatomy of the upper calyx is close to the back of the patient. Once you have puncture from the lower calyx, sometimes the stone in the upper calyx is difficult to be reached. As the upper calyx is close to the back, you can shake the kidney from outside. Here the ureteric caster. And this is the stone in the upper calyx. Here from the back you can shake the kidney, shake the upper calyx, allow the stone to be close to the pneumatic disintegration. Flexible ureteroscopy, of course, you can reach, but however, for flexible ureteroscopy, you are in need for a dilated pelvic calyceal system. You have to come from the upper calyx or the lower calyx, and there is angle. If the angle is less than 7 degrees, you cannot use the flexible ureteroscopy. Second puncture, of course, the problem in the second puncture, if you inject the dye from the ureteric catheter, the dye may come from the first puncture of the ambulance, so you are in need to put a full catheter, inflate the balloon, so you can repuncture, you do your second puncture. Endoscopic combined renal surgery is good, but it has still this advantage that the primary insertion of the access sheath, you are in need to prestent ureter, and sometimes if there is bleeding from the puncture from the upper tract, the flexible ureteroscopy is not working well. At the end of the maneuver, you have to evaluate by endoscopy the residual fragment. Very important that the ambulance tip inside the calyx, so the fragment escape beside the ambulance tip. So you have to go backward with your ambulance, looking for fragment beside the tip of the ambulance. Lastly, under fluoroscopy, the staghorn stone, there is this shadow, we are not sure is it a stone or a dye. Just put your needle, inject saline. Once it's a dye, if it is a stone, it will not disappear. If it is a dye, it will disappear. If you have a radiolucent stone, you should at the end inject the dye from the arterial caster. If it is radiolucent, this is the initial radiolucent stone, at the end of the case to evaluate, you should be completely free from radiolucent stone. The colon, if you are, this is a colonic gases and you puncture this calyx, if you are, I'm about just 1 minute. If you are about would like to confirm that you are away from the colon using this movement, or inject the dye from the nephrostomy tube, or even visualization of the tract, this you have to check for any colonic injury. If there is a check of pleural injury, you can under fluoroscopy evaluate the costophrenic angle. The exit strategies, double J insertion, either antegrade or retrograde. Very important, the last slide. Once you insert the double J, when it is indicated, the proximal coil should be inside the pelvic cell system, should not be in a trauma. Sometimes there is a trauma. You should ensure that the proximal coil is inside the pelvic cell system and it is not outside the kidney. The kidney, this is the entry of the kidney parenchyma, the inlet of the parenchyma. You should ensure that your double J proximal coil is inside the pelvic cell system. Smooth C never made skilled detailer. All of you are invited to attend our Egyptian annual meeting. It will be in the middle of December. And for those who will attend the AUA Milan, I invite you to attend. I have 2 lectures. First about pediatric PCNL, the second about puncture, how to be successful in difficult cases. Thank you.